You could start, Dr. Saida.
Okay, again, hi everyone, and welcome to our second Research Cafe. And our topic for today is comparison of conventional formulas and machine learning models for estimating serum lower density lipoprotein cholesterol. And our speaker, the main speaker is Dr. Fahad. And Dr. Fahad is well-known to most of us. Dr. Fahad is the Dean of the Oman College of Health Sciences. He holds a PhD and he was an associate professor in Sultan Qaboos University, Department of Biochemistry. His work focuses on clinical biochemistry, cardiovascular risk assessment, and molecular machines in cancer pathogens. And our expert for today, Dr. Nafila Ryami, who is an assistant head of department and senior consultant in Sultan Qaboos University Hospital. Her academic background, she earns an MD from Sultan Qaboos University, and then she completed her postgraduate training at University of British Columbia in Canada. Also, she has a fellowship from the Royal College of Physicians and Surgeons of Canada, and hold an American board certificate in clinical lipology. Her research expert, she is interested in improving clinical biochemistry testing, laboratory quality management, and diagnosis of molecular gramopathogens. She has a very broad collaborative initiative in different studies, and she is well-known for her long-term expertise in her field. Welcome to our speaker and our experts, and welcome to our audience. And we can start our session with Dr. Fahad first.
Thank you. Thank you, Dr. Saida. Thank you very much. And I'm very happy to actually present as a second in this research cafe. I would like also to welcome Dr. Nafila. She's a colleague and we've been working together for many years. And I know some terms in biochemistry are very difficult to pronounce. Inshallah, it will become very easy, inshallah, in our presentation. So I was asked to present about one of our publication that we recently published. So this is about the paper which is published in Practical Laboratory Medicine. So basically, it was me and Nafila. We were supervising our resident Ruqayya Dahli. So we got it published by this year. And we also have some members from the clinical biochemistry part of us in the paper, and also two students from the Oman College of Health Science, where they actually worked on the machine learning models later on in the project. So what I'm going to present today is basically a comparison study. It's part of a diagnostic accuracy study. We're basically targeting accurately measurement of LDL cholesterol. So whatever I'm presenting is actually an applied research, and it's a policy research that we're going to explain later on while I'm talking about the paper, why this is actually an applied, and this is actually something related to making some policies in Oman that related to health. So when you talk about a diagnostic accuracy study, the main goal here to accurately diagnose a patient, whether he has a disease or no disease. So when you're talking about LDL, we wanted to talk about accurately defining an LDL cholesterol level in the blood. Why is that? Because we want to avoid false positive. False positive is when you wrongly identify a patient having a disease. So for example, somebody who having high LDL, and your machine or your method or your calculation is not accurately detecting. So basically this individual will be labeled as a false positive, and he will go under treatment, under a new way of management. So that will affect his life later on. And also we want to reduce the false negative when you want to become more accurate. False negative when actually you have somebody and who have a disease, who have a problem. For example, here in this case, have high LDL cholesterol, and then you tell them that you don't have a high LDL cholesterol, so your method is not accurate. So what that basically is define diagnostic accuracy study. Whenever you apply any method or any tool, you need to be more accurate in identifying a patient with the disease. What we talk about today is actually about a test. It's called the lipid profile, where basically a patient will go to measure total cholesterol, his HDL cholesterol, his triglyceride, and also LDL cholesterol. This is a very important test, and you can actually, it's a high demand. And any hospital, you see there is a high number of tests done every day in any hospital. Basically, if you go to a diabetic clinic, a psychiatric clinic, a cardiology clinic, or primary care clinic where people goes there to measure LDL for a purpose of screening. For example, in Oman, we do this age of 35, where everybody goes and do a screening, and lipid profile is part of it. Sometimes it is used for treatment goal, patient with heart problem, patient with diabetes, patient will already have a high LDL cholesterol when you want to monitor the dose of psychiatric clinic, for example, some of the drugs that can cause high cholesterol. So all of this actually involved in measuring a lipid profile. And one of the very important tests is actually the LDL cholesterol, because LDL cholesterol is the main target for cardiovascular disease. And it is actually used for stratification to find the patient with high risk of developing MI, or to adjust the dose of statin, and we use the LDL cholesterol. Now, LDL cholesterol, the way it is measured is actually calculated. So we actually don't measure it in the lab. We usually use the value of total cholesterol. We subtract it from the HDL cholesterol, and then subtracted the cholesterol in the VLDL, which is the triglyceride, in the factor of 5. So it is a calculated, it's not actually measured. And the reason why we calculate it, because measurement of LDL cholesterol is very expensive. There are some techniques that require separation of lipid particles. And there are other techniques which I can directly measure the LDL cholesterol without separation. But these are very expensive tests and very expensive kit. So for a test that is routinely done and high demand, and there's a lot of samples coming to the lab to be measured, it will not become like a cost effective. So many labs in the world and around the world, they actually calculate the LDL cholesterol. And the first formula that has been established was called the Friedwald equation. And this is actually the Friedwald equation that is used. This is in milligram per deciliter. And here in Oman, we use millimole per liter. So we divide the triglyceride by 2. And since the establishment of health system in Oman, this Friedwald has been used from the start. So until now, if you go to any hospital, they use the same formula. And this is actually used most commonly in most of around the world. They use this formula to calculate the LDL cholesterol. And as you know, that hypercholesterolemia in Oman, actually more than 1/3 of Omanis, they have hypercholesterolemia. So imagine the number of tests is being done daily in primary care, in hospital, about when you're measuring LDL cholesterol. Now, the problem with the LDL, this formula, Friedwald, it becomes inaccurate in two situations. In a situation when the triglyceride is very high, such as in patient with high chylomicron, or like in a non-fasting sample, or a patient with some genetic problem, or when the LDL is very low. Here, the formula become inaccurate to estimate the LDL cholesterol. So what happened that since 1972, there are other formula. Scientists around the world, they start to establish other formulas. And here's some example of these formulas. Different type of formula where actually they use LDL cholesterol and they calculate it from total cholesterol, HDL, and triglyceride, but they keep changing the numbers, the factors for correction. And each one of them, every time when they publish like how these formula are more accurate than the Friedwald formula. However, in Oman, as you remember, that in Oman, we still keep using the Friedwald since the beginning. And nobody came and assessed the other formulas that actually we look around. There are multiple formula, and actually recent formula are also being published. Every time scientists trying to prove much more accurate formula. And currently there are some machine learning models that actually have more power than linear regression. So these are actually linear models. So they have much more power than linear models. So we would like to test whether these models are more accurate or not. So we came up with this idea. And then we're trying to test, is there a better LDL cholesterol estimating formula than the conventional one, which is the Friedwald that's been used in Oman since the beginning? And the second question, does new formulas, that new models like machine learning, will they perform better than the linear model that is already been published in the papers? So we did a comparison study, which is a diagnostic accuracy to accurately define LDL cholesterol. We took a blood sampling So we took any sample that is coming from the clinic, and we divide them into two groups: normal triglyceride, intermediate, group number 2, and those individuals with high triglyceride, which is group number 3. And then the sample that we receive, actually it goes under routine analysis using the Roche, using the LDL formula. And then we actually used one of the reference tests, which is the direct LDL assay. And again, we use the Roche machine to measure the direct LDL assay. So this was like more like the gold standard test that we use in our studies. So this is actually the correct test that we supposed to give us the most accurate measurement of LDL cholesterol. And then we try to compare the LDL cholesterol from the calculation, from all the model, and using also machine learning models. And we reported the bias, which is the difference between the two, correlation, and using Blatt-Altman plot that we're going to show you later on. So this was the demographic study. So we have around 303 samples distributed between male and female. And we calculated their lipid profile. And you can see here, this is actually the LDL cholesterol, which is measured by Friedwald, which is the current one used in the hospital. And this is actually the LDL cholesterol in each sample. And so on average, we can see that we have like around 0.2 difference between the one which is calculated by Friedwald and the LDL cholesterol that is directly measured by the machine. So the first thing we did, we tried to see which one of them is more correlated with the directly measured LDL, which is our gold standard, or like we call it the reference test, not the gold standard, it's like a reference test. And we can see the Friedwald is around highly correlated, it's very high. But we found other 3 equations, Vyjovich, Povali, and DeLong, are also highly correlated more than the Friedwald equation. The only difference we found that the equation proposed by Ahmadis from Iran is not very well correlated. It's very weak correlation. You can see sometimes it's with other correlation it goes to 0.37, but with the direct one it's 0.1. And we actually realized that Ahmadi is actually a formula that is established for only those patients with very low LDL. So it does not actually fit with our population because we did not include patients with a very, very low LDL cholesterol level. So that's why the reason it came very weak in the correlation. And then we tried to establish the correlation in different triglyceride groups. So the normal and the intermediate, the middle one, and the high triglyceride group. And we can see that actually the correlation still maintains very strong in all of them. It goes lower with the high triglyceride in most of the formula, but still is a strong correlation. It's not like very bad. So that's one of the things we looked in the paper. And then we tried to establish the bias, which is the difference between the direct and the formula, across different LDL values and across different triglyceride values. So this is what we call the Blatt-Altman plot, where you can actually look at the difference between different values. And we can see that there is no trend that whenever LDL goes up, there is no trend that there is a difference in the bias. So the bias does not change. But you can see with the higher triglyceride, we can see a positive. So whenever the high triglyceride goes up, we can see more bias coming up. The difference is becoming higher whenever the triglyceride goes up in most of the formulas, but it's still not very significant. So the first observation we found that when you look at the Friedwald, we can see the mean bias is 0.17. So Friedwald actually underestimate the actual LDL cholesterol by a value of 0.17 millimolar. Let's say that you have a cholesterol which is 2.17, which is your actual triglyceride, LDL. But when in the lab, it will be reported as 2.0 because there is a bias of 0.17 with the Friedwald. And then we look at the other formulas. We can see the highly correlated, which is DeLong. We can see DeLong is around 0.03, which is lower than the Friedwald. And the most better one is actually the Povali formula, where the bias is actually 0.005, which is less than like 3 decimal points. So that actually the Povali outperformed the Friedwald formula in the sample that we did in our study. So that's the reason. So this came up very positive. So it's very highly correlated, and the bias is much better. It's insignificant compared to the Friedwald, which is 0.17, but the Povali is 0.005. So that's actually we're trying to say that this is the bias and the 95 confidence interval. We can see that actually Povali is performing better in terms of the bias. And the Friedwald was like more bias in the Friedwald. The next question we actually did is a machine learning model, where we actually converted our sample into 60 to 40% split for validation and training. And so we used some of the 60 data to build the model and 40% to validate the model. And we looked at the different performance of the model using the internal validity and the training and the test data. And what you can focus here, that actually we use different machine learning, supervised machine learning model, artificial neural network, ridge, boosting, decision tree. This is all we have tried. And you can see here, if you look at the bias, it's almost similar. It's around 0.1. If you look at the average, it's like 0.1. So artificial neural network was better performance in terms of the mean correlation, and also in the bias is 0.09, while the other also was 0.1, 0.1, 0.12. So they are not like major difference between them. However, when you look at the difference between the Povali was even much better, so 0.005. And here actually we look at the Blunt-Altman plot for ANN. So you can see here the ANN, the mean bias, and also across the triglyceride. You can see the more the triglyceride, we can see more bias, where actually the bias becoming higher whenever you go higher triglyceride. So the paper we actually published, and the conclusion that we want to say the accurate estimation of low LDL lipoprotein cholesterol is very fundamental for cardiovascular risk stratification and therapeutic monitoring. It's a routine test. It's been heavily used in the hospital. And what we actually found that actually the two formula, but the Povali formula was the highest in overall correlation, and Povali one showed the lowest mean bias. So what we want to recommend as a policy research, part of this data is actually to send to the decision maker that if they can replace the Friedwald formula to Povali, that will be like one of the recommendations that we came up with in our paper. And so this is something that we wanted to have it more like applied research, more like a policy research. So this kind of data are very important, and it can help to minimize the bias in the LDL. And you can see the bias between Povali and Friedwald is not big significant, but even like a 0.17, which is reported in Friedwald, that can be very crucial, especially if the patient in the borderline. So that may affect those patients in the borderline. So this Povali one will have a better estimation power than the Friedwald formula. So that was the conclusion. Just trying to say that some of the work that we've been doing that is related to diagnostic accuracy study is this is actually one of the graphical chart of presentation of diagnostic accuracy study, where you can have actually participant. Then you have a reference test that you actually use, where you actually can categorize your group having a disease or no disease. And then if you have a new test, you want to test its performance, then it can, some of the tests, out of those who have positive disease, some of them will be positive and some of them will be negative. And those who have no disease, we call the control group, will be positive by the test and negative by the test. So based on this 2x2 table, you can actually calculate a lot of predictive power, sensitivity, and specificity. And these are all the components of the diagnostic accuracy test. Just showing some example, we've been working along with Dr. Nafila. We've been working with Dr. Ilham Al-Risi about the anti-Mullerian hormone for PCOS diagnostic accuracy. This is actually another hormone that you can measure in clinical biochemistry. And we have done some model like looking at the Rotterdam criteria and the new Rotterdam criteria to accurately diagnose the polycystic ovarian syndrome. The other thing we also worked with was looking at the immunoassay, heavy light assay, and comparing it to the immunofixation for multiple myeloma, looking at the IgA lambda, IgG disease or IgA disease. So we did multiple experiments, and we actually reported some ROC curve with sensitivity and specificity data. So this is also another way we looked at diagnostic accuracy study in multiple myeloma. Something similar that we did also was when we developed a new SARS-CoV detection assay with real-time PCR. So we use different markers, the ER and S gene, and also a control gene for extraction. And we actually looked at the accuracy. We can see very accurate results. So those we identified by our test positive, they were actually positive by the current diagnostic test. Those who were negative in our test were defined by negative, but 0 and 0 were like the discrepancy. So this actually shows some of the diagnostic accuracy study that we have done. We have multiple more, just trying to minimize for the time just to describe this. So this was the part of my talk. I'm happy, Dr. Saida, to take over. for any questions and discussion. Thank you very much.
Okay, thank you, Dr. Fahad, for this information. I know it's maybe higher than my level of understanding, but it's really a good work, and we are open the floor for the people who wanted to ask Dr. Fahad any questions.
I think the floor would go for Dr. Nafila. Dr. Nafila.
Assalamu alaikum wa rahmatullahi wa barakatuh. I'm just ready for questions because my understanding is that I'm here. First of all, thank you very much for Dr. Said and Dr. Fahad for the very kind invitation and the kind introduction. And I'm happy to answer any questions regarding the what has been presented by Dr. Fahad as an expert on this. I worked with Dr. Fahad for a long time. So if people want to ask, I think this is a good opportunity to ask about the results about machine learning, because this is kind of a new approach. Now we're talking about non-linear calculations. We're talking about weighted calculations. So a smart way. So instead of us looking at using a human to actually try to come up with, or even the linear data analysis, but now you're using AI and machine learning, not AI exactly, but you can put it under the umbrella of AI, where you're looking at weighted calculations, where bit by bit, you're teaching the models to actually predict the best outcome. So that's something new for us, at least, to Oman, and relatively new in the world as well, to be using that to actually predict the best outcome with minimal cost. So that is something new in our, and I think we can all make use of that. And we should make more use of that. So that was something we learned from. And then also what Dr. Fahad definitely showed with the AMH, the concept of looking at our own populations. So population-specific studies, even though we like to do some new, innovative, and people try to look, oh, let's not repeat this, but there is a lot of benefit in looking at population-specific studies where we actually look what our Omani population needs. So AMH was one very good example where you add to the Rotterdam criteria, and then this study where we've been using Friedwald for a long time, whereas Poverelli, we found out that Poverelli was better for us. And we might think that 0.1, 0.2 might not make a difference, but actually in clinical practice, LDL now, for example, if the patient is high risk, we go down as low as 1.8 and lower to 1.4. So maybe in the future, we'll be looking at low LDL, looking at the Ahmadi equation in the future. That might be another approach. Machine learning has helped us to look at ANN as a better way. So even though ANN is slightly less complex than the other machine learning models, in this case, ANN was more useful, let's say, from the forest method, for example. So, I mean, this study has opened our eyes onto so many possibilities and outcomes that we did not expect. And another thing that we did expect and we did find, which is finding higher total cholesterols in women, which is also seen in usual populations. So it was expected. I mean, it's just a reminder that not always high cholesterol, it means high risk. It's a whole package. So inflammation comes into the picture. So now it's something else, looking at disease in totality, not only selectively. I hope what I said resonates with most people here in the audience. Thank you very much. I don't know if Dr. Fahad wants to say something and with regards to what I had alluded to just now.
Thank you, Dr. Nafila. I think I agree with you. But the issue, like here, some of the new, because most of the many clinicians are going toward machine learning and the new complex model. I think that will work if you have more inputs. Currently, with this LDL formula, we actually our input were only total cholesterol and this HDL cholesterol and the triglycerides. So the only few parameters, and also the age was part of the model. So the input criteria that we put the machine learning, so that's why the linear model outperformed the machine learning model in that sense. But however, if you have like more input data that can define, but currently that can maybe enhance the machine learning model. However, in the hospital, in the current practice, where whenever you get a lipid profile, the limited input data that you don't, clinician will not try to include each of the data that for the patient. So that's why I think we kept it more simple, like what reflects in the current clinical practice. Thank you very much. And I think what you mentioned about the other population ethnicity, that is very important. As you realize what Dr. Nafila has mentioned, I actually I specifically put the heavy light assay, where the lambda chain and the kappa chain, there's a lot of ethnic variation. And that's actually one of the reasons why we did the study. We wanted to have our own local reference range. And that's actually what we've been successful, and it's currently actually used in the practice. The study data that we actually, with Maya Shedani, she was one of our residents. So her data has actually been currently used as a reference range, not only in Oman and actually across Oman with the Arab population. So maybe we can welcome other questions. Maybe Dr. Said, you can see someone raised their hands.
If there is a question, yes, Nibras.
Assalamu alaikum.
Assalamu alaikum.
Thank you, Dr. Fahad, for this nice approach where you compare simple formula with very advanced, sophisticated machine learning formulas. So my questions, Dr. Fahad, the first question about serving this model in clinical practice. So we know that most of the models, they end up just in publications. So what could be the next step to take it in the practice rather than just being hosted in papers?
Yeah, thank
so
you.
The second question, sorry for that, is about the complexity of the machine learning, how they handle like such. I mean, if we have just small input, the machine learning is supposed to handle the data in very nice a way to separate between the different classes or predict the outcomes. So how we can explain in this scenario that the most sophisticated machine learning cannot actually detect the accurate number?
Thank you very much, Dr. Nabas. I think the next level of this research, as you remember that the Minister of Health has established certain expert group, and recently last month, and I think they established one group for lipidology. And so I think it will be like if you can mute someone. Yeah. So that could be one of the things that it could be raised for like a translational, what you call knowledge translation. And that's what actually our plan. There is an expert group that actually looking at the lipids and lipid profile. It's just recently been established by the Minister of Health. So those are the group that we can discuss about the translation of this and whether it can be applied in the clinic where we can have more. And remember that one of the limitations is that we used only one platform, which is Roche. We are not sure that we need, if we want to do it in another machine like Siemens, and it depends on the clinical biochemistry, what are the machine and the kits that have been using for LDL cholesterol, like for total cholesterol and HDL. So this could be one of the questions, because currently our data is based on one platform. So translating to another platform is another question. Yeah. And as you said, for the machine learning, yes, I agree with you. With the machine learning, that what we did, we actually used some learning curve to look at the performance on the testing and the validation set. So those learning curve, we tried to show some of the models were not very good. So the only model that we actually found was the artificial neural network. What I was presenting is only the bias. I have not shown the learning curve, but in the learning curve, the artificial neural network outperformed the other models. So that's why we stick on the artificial neural network as a model.
So Dr. Fahad, if you allow me just to ask another questions. So basically we know those formula, the simple formula, it's work with some limitation, like especially the level of triglyceride.
Yeah.
But how we can take this concept into machine learning? How the machine learning consider the limitation of those formula?
Yeah. As you can see, we included patients with high triglyceride. But in the clinic, sometimes we get patients, especially with familial hypertriglyceridemia, where the level of triglyceride can go beyond 5 millimolar. We have seen patients with 10 and 11 millimolar, and those are very severe cases. They're rare cases, but we do see them in the clinic. But in those cases, whenever the LDL cholesterol is an importance, then you don't rely on the formula. And I think you can go for LDL direct measurement in those kind of patients. And maybe Dr. Nafila can comment on this, because you have seen patients, because I worked on patients with severe familial hypertriglyceridemia, but I'm not sure whether you have considered measuring LDL cholesterol in this patient.
For those who are يعني the estimation of LDL is not valid, then there's no point in doing the machine learning or the you might go for the direct, but even the direct will at some point will be a limitation.
Yeah.
And basically it comes from the beta quantification. That is the best, yani ultracentrifugation.
Yeah.
But then I have to remind everyone, it's not just about LDL, is it? It's about the total risk assessment. And that's what I mentioned, that looking at the patient, re-looking at this whole thing. I mean, I know we're focusing on the calculations, but we should really re-look at the whole risk assessment. And that's what Dr. Fahad was mentioning. Should we actually add more data in machine learning? And what data should we actually add so that the risk scoring actually corresponds to the level of severity of disease in the patient, if you know what I mean. Yani, should we just go blindly down the path of improving and increasing accuracy of machine learning and all different formulas? Or is our main goal is to actually estimate risk properly in patients and accurately that predicts outcome, morbidity, and mortality? You get what I mean? So therefore we add more, and so it's not just blindly adding numbers that will not actually predict the outcome. So for example, if we have very high triglyceride, if it's at the point of 11 and 12 and 13, at that point you're worried about acute pancreatitis in the acute stage. You're not worried. You're not worried at that point about what is his cardiovascular risk assessment. And that patient at that point, especially if it is approaching 20, the patient will be kept nil NPO and be giving nothing by mouth, and he will be we will start to manage to prevent acute pancreatitis if they have not already developed acute pancreatitis. So what I'm trying to say here is the approach to patient care will be holistic rather than looking at one area. I hope I answered the question.
Thank you.
Okay, thank you. Dr. Abdullah Al-Blushi.
Assalamu alaikum. Thank you, Dr. Fahad, Dr. Nafila, and all other colleagues. My question is about the equations used I mean, the extent of fitness of the equations to our data. So why did the Ahmadi's equation did not fit as good as the other equations? Could it be, مثلا, population tailored equation? Well, it's all generic equations.
Yeah, thank you, Dr. Abdullah. As I stated, actually the Ahmadi equation, when it was established, the formula itself, it was more targeted for patient with the very low LDL. So that's why we actually just put it as an extra model, as a validation, to just make sure that it actually will work like other formula or not. As you can see, it does not fit in our population. So basically, Ahmadi calculation is more targeted for patient with the severe low LDL. I just try to show it as because whenever you do some model and a comparison of model, you include one model that is we call it an outcast, that is like a validation to make sure that it's not correlated well with your formula. So yes, Ahmadi is not actually fit for our model. It is actually more fit for a specific population with low LDL.
Sorry.
Yes, Dr. Nafila? Yeah.
Abdullah, or I will move to Dr. Hasna.
Yeah, Hasna, yes, please.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, Dr. Fahad, for presenting your research and the findings of your study. And I would like also to take an opportunity to welcome Dr. Nafila. I actually had a question that's related to the changing the policy itself. Now, with this valuable findings of your study, I would like to know, are there going to be, or do you estimate that there will be some challenges, technical or even administrative challenges to change the policy in Oman? That's basically my question.
I think changing a policy is all related to the lab, because daily, sometimes, you know, some of the lab, when they run some validation assay, sometimes they do change some of their policy local based on their validation assay. And I think when taking over this Friedwald and converting to other formula, I think it should be taken by a consensus of the clinical laboratories, a consensus between lipidologists and cardiologists who can actually meet and look at this data. I'm not sure, Dr. Nafila, we're using Roche in the SQUH. Is it Roche also same used in the Royal Hospital, or I'm not sure if the hospital
no, Royal Hospitals are not using Roche. They're using Siemens.
And Siemens, yeah.
But they don't have I'm not sure if they have the direct LDL assay, yani.
Yeah.
But whatever it is, yani, we have to see whether it is worth changing. Meaning, does it have direct? I think it is, because even if the cardiologist and the lipidologist are using LDL as a primary target of therapy. What do I mean primary target? Yani they're looking at LDL and they're deciding whether to increase the statin dose, decrease it, or actually stop it. So that means it's a direct therapeutic target. So for example, if someone is like very high risk, they want to bring it down to 1.8, or in some cases, people will say 1.4, depends on what you're following. Okay. And so if it is that tight, so it's only 0.4 units, it's that tight, then it's worth changing the equations. The question becomes, is this sample size that's done in one center, is it enough to make that decision? Or we want to do it, or is it we can transfer the data as is to Royal? In my view, it doesn't matter. If you've used the direct LDL method, whatever the platform, as long as you've compared it to the 12 equation, it has a certain, what do you say? It has a certain value, because at the end of the day, there's certain things in the assays we have a major calibration called primary calibrator called standard reference materials. All calibrators are actually linked to standard reference materials, and the standard reference material for LDL is most likely all the way traceable to the gold standard of beta quantification. So whether I take Abbott, I take Roche, I take Beckman, Siemens, they will all trace back to the beta quantification method. As long as you use the gold standard and you compare it to the equation, then it is easy then to do a correlation between, you just take your whatever you found and just do a simple correlation between us and, let's say, if in fact Siemens have a direct LDL method, we take just 40 samples, compare that to the Roche, look at the correlation factor. If it's tightly correlated, then what applies to the SQUH, whatever we found here in SQUH, will probably apply also where to the Royal Hospital. You don't have to repeat the whole experiment again with the Royal Hospital. Okay, maybe we want to increase the sample size of those patients who are the low LDL, and then relook at the Ahmadi formula. That will be interesting to do, because we don't have a low LDL. The high triglyceride, you're going to you're probably going to underestimate LDL in those cases. So you need to find, then using the direct LDL assay would be better. I'm not sure if I answered your question, Dr. Hassan.
Yes, you did, but what you're recommending is probably just repeating a study with a bigger sample size, but I will also recommend to consider multi-centers as well, okay, for...
No, actually, I meant multi-center. I didn't say bigger sample size. The sample size, the power of the study is good, because it's based on we took the experience of what others have done, and based on the bias of the tight bias of the Friedwald, which is 0.18 compared to so the power is good. I'm saying sometimes you don't have to repeat just for the sake of repeating. The multi-center, if we're going to do multi-center, we have to think about it as what is the added value of doing the multi-center? The population is the same. And if you're going to look at platforms, well, you can just do a simple, what we call method correlation. And if they're all using immunoassays, which they are, direct, if in fact Siemens or Beckman, they do have, because not, by the way, not all companies have a direct LDL assay. Not all of them have it. So if we want to repeat it, you have to see whether the company that is, they do actually have direct LDL. If they do, you need to go back to the method and then look at the standard reference material. If it is actually traceable, then you can do a correlation study. And a correlation study or a method comparison study is nothing more than 40 to 60 samples. Then whatever you get, then there's a good correlation. You can actually compare. If you want to repeat it, nobody will stand in your way. Repeat it if you can. That's fine.
Yeah.
I think our time should be more spent on developing the machine learning models and looking at ways making, we have to get a better conclusion, not to come to the same conclusion. You know what I mean?
Yes.
Not just repeating the exercise for the sake of repeating, but rather what am I gaining from the repetition? How can I add more value to the next step in the approach that I'm going to take?
Absolutely. Thank you very much, Dr. Nafila.
And I think I agree with Dr. Anaf. The sample size is actually more beyond that what we need. So it's very powerful. Actually, for paired analysis, 30 sample size is more than enough. But we actually included 100 per group. So that actually was a strong inclusion in our study. But for other platform, whenever it goes Siemens, and I think do agree with Dr. Nafila, since you have the reference material, just doing some simple correlation in the other hospital and looking if whether this formula is outperforming Friedwald, and that can make a better decision. Yeah. I think in Oman, we do need a consensus between the clinicians who are actually managing patient and using LDL cholesterol. And I think those decisions can be used to modify the equation in the hospital.
Thank you, Dr. Fahad.
Okay, your question took me to ask another follow-up question is about if we are designing a follow-up study, what would be the single most important improvement?
And I think for me is maybe we can include patient with high triglyceride beyond 5 millimolar. That's one of the things. We want to see whether, because currently the highest sample we received today was almost around 5 point something. But sometimes we do get patients with a very rare, but you do get them with a very high, and this is actually familial hypertriglyceridemia. And the other take-home message, we maybe try the other platform with the see whether this could be a difference, yes or no. And I think those are the take-home messages that I want to.
شكرا دكتور فهد. أخت جميلة, you were at the beginning raising your hand. Do you still have a question, or I can move to the other person?
Can I say something, Dr. Saida, in follow-up with what Dr. Fahad? The problem with adding high triglyceride, and that means we can actually research that. The whole point that Friedwald said that we cannot do it because we underestimate LDL, because we know that when you have very high triglyceride, we end up having small dense LDL.
Yeah.
And this small dense LDL cannot be estimated accurately. And the ApoB particles will increase.
Mm-hmm.
So that becomes, a kind of a problem there. But that doesn't mean that machine learning cannot overcome these, In linear mathematics, yes, we could not overcome these problems. But the question is, can machine learning overcome the high triglyceride problem, right, in these patients? And we have a lot of patients with high triglycerides for the simple fact that we have a lot of patients with type 2 diabetics and chronic kidney disease. One of the two common causes of hypertriglyceridemia, secondary hypertriglyceridemia in our population. It's very common, to have patients, but not above, not above 7. But it's not uncommon to 5 people approaching 4.5, 4.6, 4. And the cutoff is 4.5. Above that, we don't use the Friedwald. And some people say above 5. So the question becomes, can machine learning overcome the boundaries that Friedwald, Pavelli, and Ahmadi, and all of those, can machine learning overcome that boundary? That becomes an interesting question.
Yeah, I think the small LDL, small dense LDL is another question. So even patient with high LDL, You might see some of them having small dense, some of them they don't have a small dense LDL. So that's another topic of research. But however, going back to the machine learning, and that's what I'm trying to state back. In the machine learning, when you try to input, like the more data you put for the model to have a better predictive power, like you can need to put more parameter, not just total cholesterol, HDL, and triglyceride, like and the age or the sex of the patient. So that's become more. You can input more data, but then you have to think about the in the clinical practice. Can you include all of those data? Like if you have a patient, you want to have more data. For example, you want the systolic blood pressure. You want to add the sugar value. You want to add the EGFR in the patient. So this is an extra cost, an extra parameter that you need to measure to put in the machine learning model. So with the current platform using only the lipid profile parameters, we can see the linear model outperforming the machine learning model. It's all about how much you put and how much you get at the end.
Okay, our question next move to Dr. Abdulrahim Al-Abri. تفضل.
السلام عليكم. شكرا Dr. Fahad and Dr. Nafila. Just my question is, Dr. Fahad, regarding to the formula you are, the Volvella formula. Now you have said in the presentation, and also Dr. Nafila have also mentioned that it's somehow relative to the ethnicity of the population themselves. And since we don't have the exact ethnicity of any patient, other than probably the self-reported or probably the maybe from the observation or from the name of the patient, how can you know that this formula will be good for this patient, or the classical formula might be the best for them? And that also can we use AI in such a way to decide which formula should be used for this patient instead of just using one formula?
Yeah, thank you, Dr. Abdulrahim. And I think what Dr. Nafila stated at the beginning, whenever there is a new analyte that comes, actually it will be seen that it will be measured in Caucasian, in African, and Asian. Sometimes we do see a population difference. So when she started to say that the ethnicity that she was referring them in a general world ethnic subgroups. However, in Oman, when you see that regarding to HDL, I think 50% of our population, and this is actually what one of the findings we see in most of the patients, is our HDL is low. Nobody knows is that HDL is low. Is it because it's something with ethnicity that in the Arabic population, and it's not, I'm not talking about only Oman, I'm talking also about GCC. Is the HDL is low? Is it because of genetic background, or is it something related to health and disease status? So that's something like it come up. So that's why when you have a sometime whenever you run some of the formula that's actually been validated somewhere else, where the HDL is actually most of the population reporting normal HDL, but in Oman our HDL is, as I said, we actually find it very frequent, more than 50%. We did one screening in Nizwa in the Dakhliya region. Almost more than 50% of the people were having low HDL. So that's why running a new formula, running a new analysis in your own population sometimes is worth doing. So that's what basically trying to state here.
Okay, Dr. Zahra, you can ask your questions. Floor is yours.
Hello, assalamu alaikum everyone. Thank you very much for the very high-profile research findings and the topic of Dr. Fahad and his team and his colleague. My question is so general about the prevalence of high cholesterol level in Oman, among Omanis generally, since you both are experts in this field and you have done and published research among that. There's a myth circulating nowadays in the social media saying that Arab ethnicity, actually, they have high cholesterol level, and it doesn't mean that it requires treatment, number one. Number two, from my experience, I have met many young population in Oman who have high cholesterol in their level where it requires treatment. And a very good example is my son. My son, at the age of 15, he was diagnosed with high cholesterol, specifically triglycerides. It was really high, and he was put on fenofibrate for around 3 months or 6 maybe, and it was actually corrected. Although the lifestyle of my son at that point was really healthy, he was not he was not a person who's taking, I was not imposing him for unhealthy snacks and this stuff. So do you have any comments about generally the prevalence of high cholesterol in Oman, and specifically among young population, and the myth that I have mentioned? Thank you so much.
Yeah, thank you very much, Dr. Zahra. As you can see that the previous NCD, which was done in 2018, and also the most recent NCD survey that actually done in Oman, almost around 40% of our population, they have high cholesterol. Some of them actually already been identified and being treated. However, there are some of those who are actually the first time they know about it. So there's a lot of hidden, like a patient undiagnosed hypercholesterolemia. And what we also been working together here with our team from SQUH, with Prof. Khalid Rasadi, we've been working for many years for familial hypercholesterolemia. In general, in the Arab region, with familial hypercholesterolemia is more common because of consanguinity. And this has actually been reported and already been published about this, the heterozygous and also the homozygous. In general, we have actually higher prevalence compared to the world. So this is like the most genetic disease that we have in Oman. People talk about sickle cell, thalassemia, but hypercholesterolemia is actually considered as one of the most common monogenic disease that is actually more common in Oman. Currently, we have a PhD student who's actually looking at the cascade screening in families, where actually one individual identified with hypercholesterolemia, and then you go with the family. And usually there are some simple diagnostic criteria. Actually, in Oman, we use the Dutch lipid clinic criteria, which is actually based on some symptoms and signs, but also the most important is the LDL. When LDL is above 5 millimolar, it gives you higher rank and more predictive to be having familial hypercholesterolemia. So yes, generally it is common in our region.
Thank you. Thank you so much.
Thank you, Dr. Fahad. Maybe I can add to that regarding her son and hypertriglyceridemia. Maybe beyond that, I think if he is not familial combined hyperlipidemia, yani the cholesterol and triglycerides are not almost equal, LDL, yani if it is not coming from VLDL, then it is worth looking if he has something called ApoC2 deficiency, or lipoprotein lipase deficiency, or hepatic lipase deficiency. Even a partial LPL deficiency can cause that, provided he has nothing, his thyroid function is normal, adrenal function is normal. So all the secondary causes should be ruled out. And you're saying he's healthy, so I assume his blood sugar control is very good. But then is the hormonal, has he been investigated for the hormonal aspects, like the cortisol, like the thyroid, like all of these have to be excluded, especially in a young man like him, 15 or so. And then if that has been excluded, then you go on to see the pattern of dyslipidemia. If you see that the cholesterol and triglycerides are almost equal mole to mole, then this is most likely familial combined. If it is not, if there is abundance of triglycerides, then it's worth looking even at partial LPL deficiency, which is lipoprotein lipase deficiency, ApoC2 deficiency. These are the more rare types, but it doesn't mean that he cannot have it. And we have something called LCAT deficiency. So these, you need to go through the pathway of excluding primary hereditary hypertriglyceridemias. Thank you.
MashaAllah. Thank you very much, Dr. Nafila, for all this. I just would like to add that only liver lipids enzymes were checked, thyroid, I think, and they were all normal. But he had a history of laparotomy, a surgery where his المرارة was incision was made there to remove something from his tummy. So I don't know if this has a relation to that or not.
Yeah, there would be a relation. There would be a relation between cholesterol stones, familiar. It is common. So I think he needs to investigate it more regarding what is the real cause of the hypertriglyceridemia. in his case, and whether it is familial combined or it is truly familial hypertriglyceridemia. That needs to be sorted out. So maybe seen by a lipidologist expert like Prof. Khalid or Dr. Khalid Waili or, Dr. Manal Kindi, one of those people.
MashaAllah. Thank you, Dr. Nafila. Thank you also, Dr. Fahad.
Okay, it was a very interesting discussion, and I think that question will continue to go, and our timing is up. And if you would like to contact the authors, you can refer to the paper, and their contact information are available. Also, if you go to the provided link about our YouTube, you can see how to contact our staff in the OCHS, Oman College of Health Sciences. And I need to close up, and I would like to thank our presenter for today. And the main thing that takes us here, this paper reminds us that the method we are routinely in clinical practice used assume not to be the most accurate, and we should question that. And we should also utilize what it had been said earlier. We should utilize what's available and the AI, and to open new ways to improve our clinical practice, to improve our patients' care and quality of assessment. And Dr. Said, it seems like you have something before I close.
I would like to thank you so much, Dr. Saida, for moderating the session, and thank you so much, Dr. Fahad and Dr. Nafila. It was nice to meet you, Dr. Nafila. Really appreciate you a lot. Salah, hopefully it will not be the end with you and Dr. Fahad, and we're looking forward for upcoming cafe, inshallah. Dr. Saida, thank you so much.
Thank you, Dr. Fahad. Dr. Said, and our speakers. It showed us how much expert, how much their minds are open for new ways to question the world around them and to dive deeper into improve their patients' care. And the machine learning and the use of the available techniques and technology, it can provide us with the open new minds to improve the quality of care. Thank you for everyone for being with us today. And thank you, Dr. Fahad. Thank you, Dr. Nafila. And as Dr. Said said earlier, I don't think this will be our last conversation, and we will see you in the future. Thank you so much.
Thank you very much. Thank you, everyone.
Thank you very much. Thank you, Dr. Fahad, for inviting me, and Dr. Saida for this lovely meeting. It was lovely meeting you all. Thank you so much.
Thank you, everyone.
Thank you. Thank you.